Now we are going to start small intestine. First of all, we are going to discuss the concepts related to bowel diverticula. Okay, so see, this is the bowel, right? And you can see this is the mesentery of bowel. Mesentery means, we discussed, mesentery means lymphovascular supply. So bowel and mesentery of bowel. Okay, in bones you have read that there is one artery which is going to penetrate the bone to supply the bone, and that is known as nutrient artery. So nutrient arteries are going to penetrate the organ to supply that organ, right? So here in the mesentery you can see that these are the nutrient arteries. Can you see? These are the nutrient arteries, and these nutrient arteries are going to penetrate the muscularis propria, and then it is going to supply the submucosa, because lymphovascular supply is present in which layer? Submucosa. Okay, now see, in this bowel, this is the mesentery and these are the nutrient arteries. Imagine if any patient who is having constipation, because of constipation there is increased pressure in the lumen. And if there is increased pressure in the lumen, what will happen? There is herniation of mucosa and submucosa, mucosa and submucosa, mucosa and submucosa. From which side? The site which is weakest. So the site of penetration of nutrient artery is weakest, and from this there is herniation of mucosa and submucosa. So this is the etiopathogenesis of bowel diverticula. So in majority of cases, this is how there is formation of bowel diverticula. Clear? So here you can see most of the bowel diverticulas are congenital or acquired, acquired, single or multiple, multiple, true or false. True means if it contains all three layers: mucosa, submucosa, muscularis propria. False means if it just contain only two layers like mucosa and submucosa. So most of the bowel diverticulas are containing only mucosa and submucosa, so this is false. So here you can see most of the bowel diverticulas are acquired, these are multiple, false. And if you see the location, the diverticula is located along mesenteric aspect or anti-mesenteric border. So here it is located along mesenteric aspect. Mesenteric aspect. Clear? So this is applicable for both small bowel as well as large bowel diverticula. Now see, there is one diverticula which is just opposite to this, and what's the name? See the diagram. So this was image based question, and this question was asked in many entrance exam. What's the name of this diverticulum? This is Meckel's diverticulum. You know, Meckel's diverticulum is congenital or acquired, so this is congenital. It's single or multiple, so single. It contains all the three layers, it means it's true. And if you see the location, it is located along mesenteric aspect or anti-mesenteric border, so it is located along anti-mesenteric border. So if you are going to compare it with Meckel's diverticulum, this is Meckel's diverticulum. Clear? So Meckel's diverticulum, it's congenital, single, true, and located along anti-mesenteric border. This is very important, so we will discuss in detail the Meckel's diverticulum. So in detail we are going to discuss the Meckel's diverticulum. Clear? So this is congenital, single, true, and located along anti-mesenteric border. So you know, Meckel's diverticulum is caused by persistent omphalomesenteric duct or vitellointestinal duct. Okay, so it is caused by persistent omphalomesenteric duct, which is also known as vitellointestinal duct. Right, now just see the questions related to anatomy. So in this diagram you can see that this is the omphalomesenteric duct, also known as vitellointestinal duct. Okay, and whenever there is abnormal persistence of this omphalomesenteric duct or vitellointestinal duct, this is known as Meckel's diverticulum. And if you see the layers, what in the Meckel's diverticulum, here you can see there is mucosa also, there is submucosa also, and muscularis also. So since all the three layers are there, it's a type of true diverticulum. Another question which is frequently asked, that Meckel's diverticulum is characterized by rule of 2. So what's that rule of 2? It is characterized by rule of 2. Right? So what's first? It is seen in 2% population. And what's the length of Meckel's diverticulum? It's not 2 centimeter, it's 2 inches in length. What's the location? It is located 2 feet proximal to IC junction, and most of the symptomatic patients are less than 2 years of age. So 2% population, 2 inches in length, 2 inches in length, located 2 feet proximal to IC junction, 2 feet proximal to IC junction, and symptomatic patients are less than 2 years of age. Symptomatic patients are less than 2 years of age. Clear? Now see the pathophysiology so that you are going to understand the clinical features. So this is the bowel, and here there is Meckel's diverticulum. Clear? There is presence of ectopic mucosa also in Meckel's diverticulum. So what is the most common ectopic mucosa? The most common ectopic mucosa in Meckel's diverticulum, and it is gastric, followed by pancreatic, followed by colonic. So there is gastric, followed by pancreatic, followed by colonic. Okay, how to remember? The mnemonic is GPC: gastric, pancreatic, colonic. Right? Now see the problems. If you see, this is the gastric mucosa, ectopic gastric mucosa, and if it is ectopic gastric mucosa, it is going to secrete acid. So can you see? It is going to secrete acid. This acid is going to work in the surrounding, and because of this acid, what will happen? There is formation of ulcer. So because of this acid, you can see that there is formation of what? Ulcer. And if there is ulcer formation, because of this ulcer, what is the most common symptom of Meckel's diverticulum? It's the bleeding. So the most common symptom of Meckel's diverticulum is bleeding. Clear? So see, what are the clinical features? Clinical features. The most common symptom of Meckel's diverticulum, and it's the bleeding. Okay? Now imagine a second situation where there is no ectopic gastric mucosa. And if patient is not having ectopic gastric mucosa, what will happen? This patient will not be having bleeding. Right? The patients who are having ectopic gastric mucosa, since they have this symptom bleeding, these patients come to us during childhood. So patient becomes symptomatic when the age is less than 2 years because of bleeding. And if patient is not having ectopic gastric mucosa, so the question is asked, what's the most common symptom of Meckel's diverticulum in adults? Why patient was not symptomatic during childhood? Because there was no ectopic gastric mucosa. Clear? So most common symptom of Meckel's diverticulum in adults, and in adults it's the abdominal pain. Right? So you have to read the question carefully. Most common symptom overall, bleeding. Most common symptom of Meckel's diverticulum in children, bleeding. And the most common symptom in adults is the abdominal pain. Now see, what's the cause of this abdominal pain? See, this is the diverticulum. If there is inflammation of diverticulum, means this is diverticulitis, there is pain. You know, Meckel's diverticulum acts as a lead point, and if it acts as a lead point, one loop of bowel is going to enter into another loop. What? This is known as intussusception. So in intussusception also there is pain. And sometimes what happens? If you see this picture, sometimes here with umbilicus there is a fibrous band. And if there is fibrous band, this Meckel's diverticulum is going to twist. So the small bowel is going to twist around this diverticulum, and this midgut is going to twist around the fibrous band, and this is known as midgut volvulus. So whenever there is twisting, it leads to volvulus. What are the causes of abdominal pain? It can be caused by diverticulitis. It can be caused by intussusception, and it can be caused by midgut volvulus. These are the causes of abdominal pain. Okay, second problem. See, it's a diverticulum, so there is inflammation known as diverticulitis, and sometimes the patients of Meckel's diverticulitis are coming to us with signs and symptoms of acute appendicitis. Right? Now see, diagnosis of acute appendicitis is purely clinical. So clinically you diagnose the patient and you are taking this patient to OT. Whenever you are performing the surgery, means you are planning appendectomy, you gave incision, and now you are examining the appendix is looking normal. So patient is having signs and symptoms of appendicitis, but appendix looks normal. In that case, you have to examine the small bowel. How much small bowel should be examined? It should be examined at least 2 feet proximal to IC junction. So small bowel should be examined at least 2 feet proximal to IC junction. Why? Because we want to diagnose whether patient is having Meckel's diverticulum or not. Clear? So if patient is having diverticulitis, patient might present to you with signs and symptoms of acute appendicitis. This question was asked in AIIMS. Signs and symptoms of acute appendicitis. So here, you perform the surgery, and what's the problem? Appendix appears normal. So how much bowel is examined? At least 2 feet proximal. The bowel 2 feet proximal to IC junction. So this complete length of ileum is examined. Imagine a second situation. If there is presence of diverticulum, obviously you have to perform the diverticulectomy, or depending upon the manifestation, resection and anastomosis. But imagine a second situation in which there is no Meckel's diverticulum. So sometimes what happens, appendix looks normal, but there are signs and symptoms of appendicitis. Even if appendix looks normal, you have to perform appendectomy. Why? If you are not going to perform appendectomy, since there is scar of appendectomy, incision you have given, so scar is there. In future, if patient is going to develop acute appendicitis, the surgeon is having this kind of impression that appendix has been removed. So whether appendix is normal or not, if incision has been given in a patient who is having signs and symptoms of acute appendicitis, appendectomy should be done. Simultaneously, we have to examine the ileum. It should be examined at least 2 feet proximal to IC junction. Now coming to the diagnosis. So how we are going to make the diagnosis? Investigation of choice for diagnosis of Meckel's diverticulum is technetium pertechnetate scan. So what's the investigation of choice for diagnosis? And this is technetium pertechnetate scan. Okay, and see what this technetium pertechnetate scan is going to detect. It is going to detect the ectopic gastric mucosa. Now see a second scenario. Suppose a patient is having Meckel's diverticulum, but there is no ectopic gastric mucosa, and in that case what? This will be negative. So in that case, what is the investigation of choice? So a second situation, if a patient is not having gastric mucosa, so in absence of ectopic gastric mucosa, what is the investigation of choice for diagnosis? So for any kind of small bowel diverticular, what is the preferred investigation? Enteroclysis. So investigation of choice will be enteroclysis. Okay, so you have to read the question carefully. Sometimes examiners are going to create a trap. They ask you, in absence of ectopic gastric mucosa, what is the investigation of choice for diagnosis of Meckel's diverticulum? And the first option, generally they give technetium pertechnetate scan, and the fourth option is enteroclysis. So correct answer is enteroclysis. Now see the treatment. So there are two situations. First, A patient is having Meckel's diverticulum with healthy base, and the second patient is having Meckel's diverticulum with unhealthy base. Healthy base means there is no ulceration around base in the ileum. Unhealthy base, can you see there is ulceration here? So if healthy base is there, can you see I can go for diverticulectomy, excision of diverticulum only. So what you do? You perform diverticulectomy and suture it. And if patient is having unhealthy base, in these patients I go for resection and anastomosis. So by resection and anastomosis, you can see I'm going to remove the diverticulum and the part of bowel, and after that I go for what? I go for anastomosis. Clear? So situation: first, if there is Meckel's diverticulum with healthy base, there is healthy base, and second, there is unhealthy base. Okay, so if there is healthy base, we go for diverticulectomy, right? And if there is unhealthy base, we go for resection and anastomosis. Resection plus anastomosis. Simple. Now imagine a third situation. You are performing elective surgery. What? Elective surgery you are performing, okay? And you notice that there is Meckel's diverticulum. You will leave this Meckel's diverticulum or you should remove it. So let me tell you, incidentally detected Meckel's diverticulum during elective surgery should be removed in all the patients up to 80 years of age. So if the age of patient is up to 80, you should remove it. Why? Because there is no added morbidity of performing diverticulectomy during elective surgery. But if you leave it, what's the problem? In 12% cases, there is complications. So there are two school of thoughts. The preferred thought is you should remove it. Okay. So important point, incidentally detected. Incidentally detected Meckel's diverticulum. It should be removed. During which surgery? Incidentally detected Meckel's diverticulum during elective surgery. Okay, it should be removed in all the patients up to 80 years of age. Why? Because the diverticulectomy, it's not going to add or increase the morbidity. But if you leave it, what's the problem? In 12% cases, there are complications. That's why incidentally detected Meckel's diverticulum during elective surgery should be removed in all the patients. Now see another important point. What are the features of Meckel's diverticulum which are going to increase the risk of complications? So in which cases there is increased risk of complications? So we'll see increased risk of complications in Meckel's diverticulum if it's narrow mouthed or wide mouthed. Obviously narrow mouthed. Healthy base or unhealthy base? Obviously unhealthy base. Presence of ectopic gastric mucosa or absence of ectopic gastric mucosa? So presence of. So three features which increases the risk of complications. First, narrow mouthed. Okay. Second, unhealthy base. And generally why there is unhealthy base? Because there is presence of ectopic gastric mucosa. Clear? So these are important points related to Meckel's diverticulum. Now we are going to discuss superior mesenteric artery syndrome. Superior mesenteric artery syndrome. Okay. What are the other names of superior mesenteric artery syndrome? It is also known as Wilkie's syndrome. It is also known as cast syndrome. Okay. What is the problem in superior mesenteric artery syndrome? The superior mesenteric artery, it is going to compress the third part of duodenum. Now see the anatomy. Now this is the anatomy. See, it's the lateral view or sagittal section. If you see, this is aorta, and you can see superior mesenteric artery arising from aorta. This is the superior mesenteric artery. You can see this is third part of duodenum. And normally what happens around the third part of duodenum, there is presence of fatty cushions. So can you see here, there is presence of fat pad, yellow colored structure. And if you see this angle, this is known as aortomesenteric angle. How much is the normal aortomesenteric angle? Its variable range is 38 to 65 degree. So first important point which you have to remember is the aortomesenteric angle. Clear? And it's 38 to 65 degree. This is normal. So imagine I'm the aorta, this is the superior mesenteric artery, and this is the third part of duodenum, right? So here the cushions are there, and it is going to prevent the compression of third part of duodenum. Because of anything, if there is loss of fat, and because of that there is loss of these fatty cushions, what will happen? The angle become narrow. And whenever this angle, in the second diagram you can see, if the angle aortomesenteric, this is aortomesenteric angle, and if it becomes less than 20 degree, in that case you can see there is compression of third part of duodenum. So what happens? This superior mesenteric artery is going to compress the third part of duodenum, and this is known as superior mesenteric artery syndrome. So any condition in which there is loss of fat, like patient is having rapid weight loss, you have seen in adolescence there is rapid gain of height, if there is cast application, if patient is immobilized for long period of time in one particular position, so all these are risk factors. Problem: if this is the bowel, okay, and there is superior mesenteric artery, it is going to compress the third part of duodenum, and because of this compression there is partial obstruction or complete obstruction. Partial. So this patient will complain that, sir, after meals in 30 to 45 minutes I'm having colicky pain, but I pass feces and flatus. Okay, so for better understanding you can see this diagram. So here you can see that this is the aorta, and from the aorta you can see this is the superior mesenteric artery which is arising. There is ligament of Treats via which the fourth part of duodenum is attached and it is fixed, and here you can see this is the third part of duodenum, and this third part you can see it is getting compressed in superior mesenteric artery syndrome. Clear? So see what are the predisposing factors. Predisposing factors for superior mesenteric artery syndrome. So first, if there is rapid weight loss, or if patient is having rapid gain of height, so these patients are lean and thin, there is rapid gain of height. Because of cast application also there is compression, so cast application or prolonged immobilization. Simple. Because of this compression there is partial obstruction, and it is most marked in postprandial period. So what are the clinical features? These patients come to you and they complain of colicky pain. There is colicky pain after meals. So you ask the question that you pass feces and flatus, and patient says yes. So what? But there is normal passage of feces and flatus. So patient passes feces and flatus. Right? Now, how we are going to make the diagnosis? We have to document the compression or obstruction. So we can make the diagnosis by CT also, or by hypotonic duodenography also. So how we make the diagnosis? Diagnosis can be made by CT or hypotonic duodenography. One important point which you have to remember, the angle. What's the normal aortomesenteric angle? We discussed 38 to 65 degree. And in which cases patients are having manifestations of superior mesenteric artery syndrome? When the angle is less than 20 degree. Right? Now see, in majority of patients, what we do, conservative management. Imagine if patient has applied a cast, we ask the patient, remove the cast. If there was rapid weight loss, we encourage the patient for weight gain, and we ask the patient that after meals, rather than lying supine, you should lie prone. Okay, so see the parts of management. In majority, we go for conservative management. Clear? What are the advices which are given? If there is cast, remove the cast. We encourage the patient to gain weight and lie prone after meals. Lie prone position after meals. Imagine there is no improvement even after conservative management. In these cases, we go for surgical intervention. And we have two kinds of treatment available. One, in which you are not supposed to perform any kind of anastomosis. Now see how we do it. If you don't want to perform any kind of anastomosis, this was asked in question. And what's the name of this procedure? This is known as Strong's procedure. What's the name of this procedure? This is known as Strong's procedure. What we do in Strong's procedure, can you see? This is the ligament of Treats. So I have to divide this ligament of Treats. And after dividing this ligament of Treats, I have to mobilize this fourth part of duodenum. So when I mobilize this fourth part of duodenum, because of this mobilization, obviously the third part also moves down and the obstruction is relieved. So what are the components of Strong's procedure? First, division. This was asked in AIIMS, division of ligament of Treats. And after that, mobilization of fourth part of duodenum. Mobilization of fourth part of duodenum. Clear? By the way, what is the treatment of choice for superior mesenteric artery syndrome? So see the diagram. The treatment of choice is, see, this is the jejunum and here is the obstruction in the third part. So what you do, you bypass it. How? With the help of this anastomosis. So you take the jejunum and you perform the anastomosis between duodenum and jejunum proximal to the obstruction. So this is duodenojejunostomy. So what is the treatment of choice? Treatment of choice for superior mesenteric artery syndrome, and this is duodenojejunostomy. Right? In short, it's known as DJ. There are other questions which are asked related to duodenostomy and duodenojejunostomy. We discussed in annular pancreas and duodenal atresia. What is the treatment of choice? Duodenostomy. So see, for annular pancreas and for duodenal atresia, in both of these cases, what is the treatment of choice? So here the treatment of choice is DD followed by DJ. So it is the duodenostomy followed by duodenojejunostomy. But in superior mesenteric artery syndrome, it is the duodenojejunostomy. Now we are going to discuss small bowel tumor. Lots of one-liner questions are asked related to small bowel tumors. So see, what is the most common small bowel tumor? Okay, most common small bowel tumor. So the most common small bowel tumor is stromal tumor followed by adenoma. It is the stromal tumor followed by adenoma. Okay. Next important point, what is the most common small bowel tumor in children? And in children, the most common small bowel tumor is lymphoma. And what is the most common malignant small bowel tumor? That is adenocarcinoma. Okay. So the second statement is, what is the most common small bowel tumor in children? Clear? And this is what? Lymphoma. It's the lymphoma. And see, third important point, most common malignant small bowel tumor. Malignant small bowel tumor. Clear? And this is adenocarcinoma followed by carcinoid tumor. So this is adenocarcinoma followed by carcinoid tumor. Clear? So these are the important points related to small bowel tumors. One topic which is very hot, asked in medicine, in surgery, in pathology, and that is carcinoid tumors. The topic is controversial, it's very hot, asked in 3 subjects. That's why we are going to discuss this topic in detail. Carcinoid tumors. Okay, so see the important points related to carcinoid tumors. Right? So first important point, that carcinoid tumor is a type of neuroendocrine tumor. What do you mean by neuroendocrine tumor? The tumors which are arising from neuroendocrine cells. Okay, so carcinoid tumor, it's a type of neuroendocrine tumor. It means the tumor is arising from neuroendocrine cell. Clear? This neuroendocrine cell, it varies depending upon the organ. So if you are talking about small bowel or small intestine, the carcinoid tumors are arising from enterochromaffin-like cells. So what are the cells from which carcinoid tumors are going to arise? It can arise from enterochromaffin-like cells in small intestine. It can arise from argentaffin cells. It can arise from apud cells or APUD cells, that is amine precursor uptake and decarboxylation cells. Amine precursor uptake and decarboxylation cells, and it can arise from Kulchitsky cells. Right? This is the origin. Now coming to the most common site. Let me tell you one important point, that in most of the surgery book, it's wrongly written. In most of the surgery books, it's wrongly written that appendix is the most common site of carcinoid tumor. See, we are talking about 2 Bibles. One is Harrison 20th edition and second is Bible of Oncology, that's DVita 11th edition. And in both, it is mentioned that the most common site of carcinoid tumor is bronchus, not the appendix. So see, what's the most common site of carcinoid tumor? So what's the most common site? And how to remember, the mnemonic is BIREX. It's the BIREX. Clear? So here, B means bronchus, I means ileum, R means rectum, A means appendix, C means colon, S means stomach. So the most common site is what? Is the bronchus, followed by ileum, followed by rectum, followed by appendix, followed by colon, followed by stomach. This is the most common site, and this sequence you have to remember, because sometimes in the option bronchus is not mentioned. So if bronchus is not mentioned in the option, which option you are going to mark? Ileum. Right? Now see the second statement. If we are going to compare 2 organs, one is small intestine and the second is bronchus, which one is the most common site? Most common site. So if we are comparing small intestine with bronchus, overall the most common site is what? Small intestine. Why? Because small intestine means it's the combined incidence of duodenum plus jejunum plus ileum. So small intestine means it's the combined incidence of duodenum, jejunum, ileum. And obviously the incidence is more in small intestine as compared to bronchus. Clear? So read the language of question and options. If in the options bronchus and ileum is mentioned, you choose bronchus, and if in the option bronchus and small intestine is mentioned, what will you choose? You have to choose the small intestine. Clear? So let me repeat. What's the most common site of carcinoid tumor? Is the small intestine followed by BIREX. It's the small intestine followed by birex, means bronchus, ileum, rectum, appendix, colon and stomach. Now see the types of carcinoid tumor. It is of two types. One is localized. Localized means it is confined to the organ. And second is non-localized. Non-localized means generally it is associated with metastasis. So types of carcinoid tumor. First type is localized. Okay, localized carcinoid, it means it is confined to that organ. And how to remember? The mnemonic is LOAR. It's LOAR, right? L means larynx, O means ovary, A means appendix, R means rectum. Clear? So this is what is the larynx followed by ovary, appendix followed by rectum. Clear? So see another important question from this mnemonic. Overall, which carcinoid tumor is having best prognosis? The carcinoid tumor which is mainly localized, not associated with metastasis, and that's larynx. So overall, if we are talking about the carcinoid tumor which is having best prognosis, and that is laryngeal carcinoid. Okay, now see in GIT which carcinoid tumor is having best prognosis, and in GIT it's the appendix. So another important point, in GIT appendiceal carcinoid is having best prognosis. Simple. Now see the types of non-localized carcinoid. The types of non-localized carcinoid means these carcinoids are having high risk of metastasis, and here the mnemonic is PCS. P means pancreas, C means colon, S means small intestinal. So here P is pancreatic or pancreas, C means colonic or colon, and S means small intestinal. So another important question, that which carcinoid tumors are having worse prognosis, and it's the pancreatic carcinoid, right? So pancreatic carcinoid, these are having worst prognosis. Clear? So we discussed three mnemonics. You have to remember, one was birex, second was LOAR, and third is PCS, right? You can crack most of the questions. So sometimes there is a twist in question. If you remember this birex, see the question, what is the most common site of carcinoid tumor in GIT? And if the question is asked most common site of carcinoid tumor in GIT, and that's ileum. Second question, most common site of carcinoid tumor in hindgut, and if it's hindgut, then it is rectum. Most common site of carcinoid tumor in foregut in GIT, and then it is stomach. In foregut in GIT. So I'm repeating three important points. Most common site of carcinoid tumor in GIT, ileum. Most common site of carcinoid tumor in hindgut, rectum. And most common site of carcinoid tumor in foregut in GIT, that's stomach. So if you remember the mnemonic, you can crack any question. Now see in GIT, which carcinoid is argyrophilic, which one is argentaphilic, and which one is mixed. So if you are talking about the foregut carcinoids, yes, the carcinoid tumors located in foregut, these are argyrophilic. These are argyrophilic. Clear? And the carcinoid tumors which are located in midgut, these are argentaphilic. So the carcinoid tumors which are located in midgut, so midgut carcinoids are argentaphilic. Okay, and hindgut carcinoids are mixed. Means it is both argyrophilic and argentaphilic, but mainly it is argentaphilic. So hindgut carcinoids, these are argentaphilic. It is mixed, but mainly argentaphilic. Clear? So this is mainly argentaphilic. Okay. Differences. After that, see, out of these three, which carcinoids are producing 5-hydroxytryptamine or serotonin? So if you see foregut, midgut and hindgut carcinoid, it's the midgut carcinoid which is mainly producing 5-hydroxytryptamine or serotonin. This is producing mainly midgut carcinoid. Hindgut carcinoids are rarely going to produce, so this rarely produces 5-hydroxytryptamine. And foregut carcinoids, these are going to produce low levels. These are going to produce low levels of 5-hydroxytryptamine or serotonin. Okay, so there is one question: out of foregut, midgut and hindgut carcinoid, which tumors are associated with carcinoid syndrome? So it's the midgut carcinoid, which is midgut carcinoid tumors which are associated with carcinoid syndrome. Okay, so there are two important points related to midgut carcinoids, that these are associated with, first, carcinoid syndrome. Okay, and it's also associated with MEN1. You have to remember, multiple endocrine neoplasia 1. So it is associated with MEN1. Foregut and hindgut carcinoids are rarely associated with carcinoid syndrome. We are going to discuss the pathophysiology so that you are going to understand the concept of carcinoid tumors. Okay, see, pathophysiology. So 5-hydroxytryptamine or serotonin, this is metabolized mainly in the three organs. So in which organs? Serotonin or 5-hydroxytryptamine, it's mainly metabolized in three organs. Mainly which organ? Liver. It is also metabolized in lungs as well as in the brain. Clear? So there is metabolism of serotonin in these three organs. There is one enzyme, monoamine oxidase. So what happens? This monoamine oxidase works on this serotonin. Clear? And it is going to convert this serotonin into 5-hydroxyindole acetic acid. So serotonin is metabolized into 5-hydroxyindole acetic acid in liver, lungs, brain. Mainly which organ? In the liver. Clear? And finally, this 5-hydroxyindole acetic acid, this is excreted in urine. So this is excreted in urine. Clear? Now, what is the importance of this pathophysiology? That how we are going to make the diagnosis of carcinoid tumors. So we are going to detect the byproduct in the urine. Which one? 5-hydroxyindole acetic acid. So this is the investigation of choice for diagnosis. We will discuss in diagnosis that we are going to detect 5-hydroxyindole acetic acid in the urine. So this is the investigation of choice for diagnosis. One important point. Now see the second important point. You know that GIT, venous drainage, directly or indirectly mainly goes to the liver. So from GIT, the venous drainage directly or indirectly goes to the liver. And in the liver, there is catabolism of serotonin. Now problem, in which patients you will see the carcinoid syndrome? Whenever the production of serotonin exceeds the metabolic capacity of monoamine oxidase. So in any patient, when the production of serotonin is going to exceed the metabolic capacity of monoamine oxidase, these patients will be having raised level of serotonin responsible for carcinoid syndrome. So imagine if a patient is having GI carcinoid and in liver catabolism is occurring, but patient is having multiple metastases in liver. So the capacity of monoamine oxidase exceeded by the production of serotonin. So these patients will be having what? Carcinoid syndrome. You know that in lungs, via inferior vena cava, the systemic circulation blood goes into right atrium, then right ventricle, and then it goes into pulmonary circulation. In pulmonary capillaries, there is catabolism of what? Serotonin. Clear? So from systemic circulation, blood goes to the lungs, and in lungs, in pulmonary capillaries, there is catabolism of serotonin. So in which patients you will see carcinoid syndrome? When the production capacity of serotonin exceeds the metabolic capacity. Clear? So production capacity of what? serotonin. It exceeds the metabolic capacity of monoamine oxidase. Then we have patients of carcinoid syndrome. And what are the manifestations of carcinoid syndrome? The most common manifestation is flushing. So these patients have carcinoid syndrome. Clear? Now see what is the most common manifestation of carcinoid syndrome, and the most common manifestation, and this is flushing. Right? What are the other manifestations? They can be wheezing, bronchospasm, diarrhea. So other manifestations are, they can be diarrhea, they can be wheezing and bronchospasm. Okay. Another topic which is asked in relation to carcinoid tumors, that's carcinoid heart disease. Now see, from systemic circulation, blood finally goes into right atrium via superior vena cava and inferior vena cava. From right atrium it is going into right ventricle, and from pulmonary arteries it is going into the lungs. Clear? And after that from pulmonary vein, left atrium and left ventricle. Now see, what is the problem? Whenever there is a tumor and there is increased production of 5-hydroxytryptamine or serotonin, this is going to right atrium. So what is the first valve which comes in contact with raised level of serotonin? It's the tricuspid valve, followed by second valve is pulmonary valve. So there are three important points which you have to remember. Catabolism of serotonin is going to occur in the pulmonary capillaries. So if you are going to compare right heart and left heart, which heart will be mainly affected in carcinoid heart disease, right or left? So obviously right, because in pulmonary capillaries there is catabolism of serotonin. In right heart, which valve is most commonly affected? The valve which comes in contact first, and that is tricuspid. And in the valve, which kind of abnormality is more common? It's regurgitation. So three important points. Right heart is more commonly involved than left. Tricuspid valve is more commonly involved than pulmonary, and regurgitation is more common than stenosis. Okay. So see, carcinoid heart disease, carcinoid heart disease. So three important points, since catabolism of serotonin occurs in pulmonary capillaries. First, here right side of heart is more commonly involved than left side. First principle. Second, tricuspid valve is more commonly involved than pulmonary valve. And third important point here, regurgitation is more common than stenosis. Clear? So what is the most common valvular abnormality? It's the TR followed by PR followed by TS followed by PS. The most common valvular abnormality. So TR, tricuspid regurgitation followed by pulmonary regurgitation followed by tricuspid stenosis followed by pulmonary stenosis. This is frequently asked in exams. Almost every year this question is asked, and it's wrongly given in Subiston, correctly given in Harrison. So if you are reading Subiston, this information is wrong. So it is correctly given in Harrison. Okay, another important point related to carcinoid tumors, that in carcinoid tumors, what are the factors on which the risk of malignancy is going to depend? So in carcinoid tumors, the risk of malignancy depends on there is a mnemonic, and the mnemonic is LSD growth. So first L we discussed, localized and non-localized, and it was dependent on location, so it's location. S, that's size. D is depth of invasion, so depth of invasion. And growth, that's the growth pattern, so growth pattern of the tumor, growth pattern. Clear? So these are the basic things related to carcinoid tumors. in general. Now we are going to discuss the small bowel carcinoid in detail. So small bowel carcinoid. So first important point, that small bowel carcinoid arises from which cells? ECL cells, enterochromaffin like cells, and these cells are located where? In the crypt of Leberkuchen. So site, these tumors are going to arise from enterochromaffin like cells located in crypt of Leberkuchen. We discussed that midgut carcinoids are argentaphinic. So this is also argentaphinic. It is going to produce 5-hydroxytryptamine, and midgut carcinoids means small bowel carcinoid is associated with carcinoid syndrome. Now see the other manifestations. Imagine that this is the bowel, small bowel, clear? And in this case, this is the tumor. See, carcinoid tumors are very small initially, and some patients become symptomatic because of manifestations of carcinoid syndrome. Now what happens in small bowel carcinoid? The tumor is very small, but it is associated with intense desmoplastic reaction. What is the meaning? If this tumor is having intense desmoplastic reaction, can you see there is excessive fibrosis around the tumor? And whenever there is excessive fibrosis around the tumor, what will happen? It is going to compress the small bowel. And because of this compression of small bowel, what happens? Patient will be having partial obstruction, and because of that obstruction, patient is having pain. So what are the clinical manifestations? Here you can see that there is intense desmoplastic reaction. So clinical features, these patients have intense desmoplastic reaction. So there is intense desmoplastic reaction around the tumor leading to obstruction, and because of this obstruction, what is the symptom? The symptom is abdominal pain. Clear? This abdominal pain is not directly related to tumor. This tumor is not doing the obstruction, is the fibrosis around the tumor which is responsible for obstruction. Okay, GI blood is finally going into liver via portal vein. So what is the most common site of metastasis? Most common site of metastasis, since the tumor is in GIT, it's what? Liver. And there was one liner question related to gastric carcinoid, that what is the most peculiar symptom of gastric carcinoid? There is bright red patchy flushing. So most peculiar feature of gastric carcinoid, in gastric carcinoid there is bright red patchy flushing. This was one liner question. Bright red patchy flushing. Now coming to the diagnosis. So we discussed when we were discussing pancreatic neuroendocrine tumors that generally in cases of neuroendocrine tumors, the diagnosis is made in laboratory by measuring the active substance or its byproduct. So what's the byproduct which is detected in urine here? It's the 5-HIAA. So the investigation of choice for diagnosis is 24 hours urinary estimation of 5-hydroxyindole acetic acid. It's the, you have to remember, 24 hours urinary estimation of 5-hydroxyindole acetic acid. Second important point which we discussed in pancreatic neuroendocrine tumors, that all neuroendocrine tumors are going to express somatostatin receptors except insulinoma. That's why in majority of neuroendocrine tumors, the investigation of choice for localization is SRS. What is the full form of SRS? Somatostatin receptor scintigraphy. So here also the initial investigation, for localization and for staging of carcinoid tumors is SRS. Initial investigation for localization and staging is somatostatin receptor scintigraphy. But if you're talking about the best investigation for localization, then it's DOPA PET. So what's the best investigation? best investigation for localization. And the best investigation for localization, this is DOPA PET. You have to remember all these three important points because all these three are frequently asked. Now, how we are going to manage the carcinoid tumors? In carcinoid tumors, obviously we go for segmental resection. With segmental resection, we go for en-bloc lymphadenectomy. So in small bowel carcinoid, we go for segmental resection plus en-bloc lymphadenectomy. En-bloc lymphadenectomy. So it's the segmental resection with en-bloc lymphadenectomy. Okay, what is the chemotherapy regimen which is given? And here the name of regimen is DEF, the chemotherapy regimen, and that is DEF. Clear? D is dacarbazine, E is epirubicin, and F is 5-fluorouracil. So D, that's dacarbazine. E, it's the epirubicin, and F is the 5-fluorouracil. So this is the chemotherapy regimen which is given in carcinoid tumors. There is one question which is asked in pathology related to prognostic marker. So what is the most important prognostic marker related to carcinoid tumors? And it's chromogranin A. This chromogranin A is raised in 100% patients of carcinoid tumors. So prognosis, what is the most important prognostic marker? The most important prognostic marker for carcinoid tumors. This was asked many times, and sometimes they are making the language. A big question is there in the format of language, and it is mentioned that chromogranin A is raised. Clear? So here there is chromogranin A, which is the most important prognostic marker. Clear? So it's the chromogranin A. This is how we manage, and this is the prognostic factor. So in management, we go for segmental resection and we perform the anastomosis. So generally you have noticed that in this whole chapter of small intestine, for most of the conditions we were performing resection and anastomosis, resection and anastomosis, resection and anastomosis. And if you are going to do so much of resection and anastomosis of small bowel, this patient is going to develop what? Short bowel syndrome. So see what happens in short bowel syndrome. Short bowel syndrome. So what's the cause of this short bowel syndrome? It is caused by massive resection of small bowel. When there is massive resection, first see what's the normal length of small intestine. So what's the normal length of small intestine? The normal length of small intestine is 600 centimeter. And sometimes they ask what is the normal length of large intestine? It is 150 centimeter. Small intestine 600 centimeter, large intestine 150 centimeter. So what is the definition of short bowel syndrome? Whenever the length of small intestine becomes less than 200 centimeter, patient will start developing signs and symptoms of short bowel syndrome. So generally in short bowel syndrome, the length of small intestine is less than 200 centimeter, and what is the cause? Massive resection of small bowel. Clear? So it is caused by massive resection of small bowel. Clear? So in which surgeries we are going to perform the massive resection of small intestine or small bowel? Most important, you have seen the patients mesenteric ischemia, where almost midgut is ischemic, mesenteric ischemia. Other causes, if the patient is having mesenteric trauma, it can lead to devascularization of bowel. Patients who are having midgut volvulus and in Crohn's disease. Why? Because on an average, a patient of Crohn's disease requires 3 to 5 surgeries of small intestine. So resection and anastomosis leads to what? Short bowel syndrome. Now see, in small bowel, it's mainly jejunum and ileum, which is having better adaptability. So ileum is having better adaptability. Better adaptability means it can adapt the functions of jejunum. Since ileum is having better adaptability, jejunal resections are better tolerated. Clear? Now what are the manifestations of this short bowel syndrome? See, if you talk about the terminal ileum first, what are the two unique functions of this terminal ileum? Here, there is absorption of B12, vitamin B12, and there is enterohepatic circulation of bile salt. Clear? So since there is impaired absorption of vitamin B12, these patients will develop what? Megaloblastic anemia. If there is impaired enterohepatic circulation of bile salt, this bile salt is not going to be absorbed. And if there is bile acid or bile salt deficiency, so these patients are having increased risk of which stone? Cholesterol gallstone. And the bile salt which is not absorbed in the terminal ileum, the bile salt will enter where? The colon. And if it enters colon, bile salt is going to irritate the colon, and because of that patient is having watery diarrhea. And what's the name of this diarrhea? Choleretic diarrhea. Clear? So first three manifestations, see, these patients have megaloblastic anemia because of impaired absorption of vitamin B12 from terminal ileum. Second, these patients can develop cholesterol gallstone. Why? Because of impaired enterohepatic circulation of bile salt, leading to bile salt or bile acid deficiency, and this bile salt enters into colon, leading to choleretic diarrhea. There is choleretic diarrhea. Watery diarrhea caused by irritation of colon with or by bile salt. You know that in jejunum there are finger-like projections. These are called villi. So there is increased absorptive surface, and because of this increased absorptive surface there is absorption. So whenever we are going for small bowel resection, there is loss of absorptive surface. So the nutrients are not going to absorb. And if nutrients are not absorbed, it leads to malabsorption. So imagine there is free fatty acid which is mainly absorbed in jejunum. So if it is not absorbed, it's there in the lumen, and free fatty acid will bind with calcium. And if it is going to bind with calcium, which calcium? The calcium which was for the oxalate. So free fatty acid binds with calcium. Now oxalate is free, and these free oxalates are going to be absorbed in the colon, leading to oxalate renal stones. So what is the problem? These patients have malabsorption because of loss of absorptive surface. Malabsorption because of loss of absorptive surface. So what will happen? Free fatty acid will bind with calcium. This calcium was there for oxalate. Now it's going to bind with free fatty acid, so it's not available for oxalate. So what will happen? The oxalates are free, and these free oxalates are absorbed in colon. And if free oxalates are absorbed in colon, there is increased risk of oxalate renal stones. So there is increased risk of oxalate renal stones. Now see another important concept. When we were discussing the intussusception, I discussed that what is the most common type of intussusception? It's ileocolic. So ileum is going into colon. And what was the surgical treatment? We were performing ileocolectomy. And we were performing what kind of anastomosis? Ileotransverse. Imagine this is the diagram. Clear? And this is the transverse colon. Clear? So we were removing terminal ileum and the part of cecum and ascending colons. And what kind of anastomosis was done? It was ileotransverse. So if you are going to perform ileotransverse anastomosis, what you removed in this patient? You removed this IC valve. Generally it is competent, so there is unidirectional movement. That's why fecal matter doesn't go back into ileum. But whenever I'm going to perform this kind of anastomosis, this is ileum, this is transverse colon. So there will be free reflux of fecal matter from transverse colon into ileum. and because of that there is bacterial overgrowth and this leads to diarrhea. This symptom is only seen in the patients where we are going to remove the IC valve. Okay, so see the problem. If in the patient IC valve is removed, if IC valve is removed, clear? So in such patients, what's the problem? In such patients there is bacterial overgrowth, and in such patients there is diarrhea. Clear? There is a hypothesis which says that catabolism of gastrin occurs in small bowel mucosa. So if catabolism of gastrin occurs in small bowel mucosa and you are going to perform the resection of small bowel, so these patients have hypergastrinemia or hypogastrinemia. So what? These patients have hypergastrinemia. So these are the manifestations of short bowel syndrome. Now see the management. Since small bowel resection has been done, there is no absorptive surface. So immediately in the post-operative period, what should be given? Total parenteral nutrition. So immediately in the post-operative period, we go for conservative management and we go for total parenteral nutrition. In which vein it is given? Most preferred vein for central line insertion for giving TPN is subclavian vein, followed by internal jugular vein, followed by femoral vein. But what is the treatment of choice for short bowel syndrome? Since small bowel is missing, so put small bowel inside. So what's that? That's small bowel transplantation. So see the treatment options. In post-operative period, in immediate post-operative period, we go for total parenteral nutrition, and it is given in which vein? Most preferred vein is subclavian vein, followed by internal jugular vein, followed by femoral vein. By the way, what's the treatment of choice for short bowel syndrome? And it's the small bowel transplantation. Small bowel transplantation. So here you can see, since the small bowel is missing, I'm going to add the small bowel. So this is what? Small bowel transplantation, but it's very costly. Most of the patients are not going to afford. So what are the other treatment options? We can go for some surgical operations in which we can increase the length of small bowel, or we can go for certain procedures where we can increase the contact period of foodstuff with the bowel mucosa so that there is increased absorption. And what are these surgical operations? First is Bianchi procedure. These are intestinal lengthening procedures. So Bianchi procedure. Okay. What is the other name of this Bianchi procedure? It is also known as LILT. What is the full form? Longitudinal intestinal lengthening and tailoring. Full form? It's the longitudinal intestinal lengthening and tailoring. Okay, now see how it's done. You can see that this is the bowel and this is the mesentery of bowel. Clear? What we are going to do, we are going to fire the stapler along the length. So like this. Clear? And when you are going to fire the length along the length, this is longitudinal intestinal lengthening. So this is the circumference, and if you are going to divide the bowel along its length, its circumference will be reduced to half. So can you see here? Its circumference is reduced to half, and what? These ends are joined together. So when you are going to join the ends, length is double. So by this surgery, Bianchi procedure, we are going to reduce the circumference to half and we are going to attach the limb, so the length is just double. So what is the advantage here? Here there is increased contact duration of foodstuff with the bowel mucosa. What is the second procedure? That is step. Second is step The full form of step is serial transverse enteroplasty procedure. So this is serial transverse enteroplasty procedure. Okay, now see how it's done. So here you can see that this is small bowel and we are going to fire. Can you see multiple staplers? So when you are going to fire the multiple staplers, can you see after firing multiple stapler, the final diagram is something like this, and how the food is going to travel? Can you see the food is going to travel like this, clear? So what happens? Because of this zigzag motion of food, there is increased contact duration of foodstuff with the bowel mucosa. So these are the other procedures which are done for short bowel syndrome. But what is the treatment of choice for short bowel syndrome? So it is the intestinal transplantation. And which part specially? Small bowel. So we go for small bowel transplantation in short bowel syndrome. This is all about small intestine. Now we are going to start GI tuberculosis. GI, gastrointestinal tuberculosis. Okay, so what is the most common organism responsible for gastrointestinal tuberculosis? It is Mycobacterium tuberculosis. It is not the Mycobacterium bovis. Why? Because Mycobacterium bovis has been eliminated by public health measures. So what's the most common organism responsible? The most common organism responsible for GI tuberculosis is the Mycobacterium tuberculosis. Okay, now see, in Indian scenario, most of us are having the infection by Mycobacterium tuberculosis. But what is the good thing? That our immunity was good, that's why the infection was cleared. In some of us, this infection is still in the dormant state. So if the infection is still in the dormant state, and if the immunity goes down because of stress, because of any other thing, what happens? There is reactivation of the bacteria. Now see, what is the first organ affected or involved by Mycobacterium tuberculosis? So it is lungs. When the lungs are involved and there is production of sputum and the patient is going to swallow that infected sputum, this infected sputum reaches ileum, and in ileum it is going to recruit lymphocytes in submucosa. And what happens? There is oxidative stress or burst and there is loss of epithelium, and because of loss of epithelium there is formation of ulcer. And what kind of ulcer? Transverse ulcer. Clear? So see the important points related to GI tuberculosis. First, points related to pathway of spread. Pathway of spread. So how GIT is involved? Clear? The first organ affected, and that's lungs. When the lungs are affected, there is production of sputum. When patient is going to swallow infected sputum, so there is swallowing of infected sputum, and this infected sputum reaches the ileum. And what happens in ileum? It's going to recruit lymphocytes in submucosa because of inflammation. So in tuberculosis there is recruitment of lymphocytes in submucosa. So there is recruitment of lymphocytes in submucosa. Clear? And there is oxidative burst or oxidative stress and loss of epithelium. And because of loss of epithelium, what kind of ulcers are formed? In tuberculosis there is transverse ulcer. Formation of transverse ulcer. Now see, what kind of ulcer is seen in typhoid or enteric fever and tuberculosis? So here we saw transverse ulcers are seen in tuberculosis and longitudinal ulcers are seen in enteric fever or typhoid. Now see these images. In the first image, can you see what kind of ulcer? Can you see? This is the ulcer. This is the ulcer. And if you see the orientation, it's what? Transverse. So can you see? So it's the transverse ulcer. So this is seen in tuberculosis. And what kind of ulcer? It's the transverse. Now see this ulcer. This is longitudinal. Can you see? This is longitudinal, and this longitudinal ulcer, it is seen in typhoid or enteric fever. Clear? So this is tuberculosis, and this is typhoid. And in typhoid, we are going to find longitudinal ulcers. Okay, now two most important points. First, earliest disease activity in gastrointestinal tuberculosis is seen in which layer of bowel? So we discussed earliest disease activity is seen in which layer? It is seen in submucosa. Second, what is the most common site of gastrointestinal tuberculosis? And the most common site of gastrointestinal tuberculosis is ileocecal region. Okay, so see here, earliest disease activity. Earliest disease activity is seen in which layer? It is seen in submucosa. Right? And the second question which is asked, that what's the most common site of GI tuberculosis? And the most common site of GI tuberculosis, and that's ileocecal region. Okay, so it's the ileocecal region or ileocecal junction. These are important points. After that, lots of questions are asked in pathology also. So see the pathological types. There are three types of gastrointestinal tuberculosis. What's the most common type? Ulcerative variety. Second is hyperplastic variety, and third is sclerotic or fibrotic variety. So see the pathological types. It is of three types. Most common is the ulcerative variety. Second is hyperplastic, and the third is sclerotic or fibrotic. Right? So sclerotic or fibrotic. Okay, see the distribution. In 60% cases, it's ulcerative variety. In 10% cases, it is hyperplastic variety, and in 30% cases, it is sclerotic or fibrotic. So most common type is ulcerative variety. Now, in which patients this ulcerative variety is seen? Whenever the virulence of organism is high. So there is high virulence of organism and there is decreased immunity. So immunity is compromised and the virulence is high. In these patients, there is formation of which kind of ulcer? Formation of transverse ulcers in ileum. Clear? So since there is formation of transverse ulcers in ileum, this is ulcerative variety. What happens in hyperplastic variety? Just opposite. When the virulence of organism is relatively low and the immunity of patient is relatively good, this patient is going to mount strong inflammatory response against the infection, and because of this strong inflammatory response, what's going to happen? There is mesenteric lymphadenopathy. The lymph nodes are going to enlarge, and in those lymph nodes there is caseous necrosis, and because of this caseous necrosis, these lymph nodes are very sticky, and since the lymph nodes are very sticky, there is formation of matted bowel loops. Okay, so this is going to happen in hyperplastic variety. So see what happens here. Here the virulence of organism is relatively low, and there is good immunity of patient. So because of this, the patient is going to mount strong inflammatory response. So there is strong inflammatory response. Because of this strong inflammatory response, there is mesenteric lymphadenopathy. So there is mesenteric lymphadenopathy. In these lymph nodes, what's the problem? There is caseous necrosis. Clear? So there is caseous necrosis and lymph nodes become very sticky, and because of these sticky lymph nodes, what's the problem? There is formation of matted bowel loops. So it leads to formation of matted bowel loops. So there is formation of matted bowel loops. What happens in sclerotic or fibrotic variety? In chronic cases, whenever there is healing of ulcer, so healing occurs by fibrosis, and because of this healing, in chronic cases there is formation of stricture. So this is sclerotic or fibrotic. It is seen in chronic cases, and in these cases there is formation of stricture. Now see, whatever the kind of tuberculosis patient is going to have, doesn't matter whether patient is having pot spine, patient is having pulmonary tuberculosis, gastrointestinal tuberculosis, initially patient is going to develop non-specific signs and symptoms of tuberculosis. So what are those non-specific signs and symptoms? Like evening rise of temperature, there is low-grade fever, there is night sweats, anorexia and weight loss. So these are non-specific signs and symptoms. Have a look. Clinical features. So initially patients are having non-specific signs and symptoms of tuberculosis, okay, and it's going to include evening rise of temperature, low grade fever, night sweats, anorexia and weight loss. So there is anorexia and weight loss. Clear? All these are seen in all types of tuberculosis generally. Clear? These are non-specific signs and symptoms. Okay, now see the specific symptoms. We discussed that the most common site of GI tuberculosis, it's ileocecal junction or ileocecal area. Now see, this is appendix, this is ileum, this is cecum. In ileum we discussed what kind of ulcer. There is formation of this transverse ulcer. So whenever transverse ulcer is there in ileum becomes hyper irritable. So whenever we eat something, what happens? The content enters into small intestine, means ileum. There is rapid emptying of content into colon. So if there is rapid emptying of content into the colon, because of this, what happens? There is diarrhea. So whenever there is ulcer, because of this ulcer, the ileum becomes hyper irritable, there is rapid emptying of content into colon, and there is diarrhea. So diarrhea is specific symptom and it is seen in early GI tuberculosis. Okay. After what happens? After ulceration, so healing, there is fibrosis, and because of fibrosis there is contraction. So what happens? Suppose this is cecum and this is the ileum, appendix. Imagine these are the sites of ulceration. So what happens? There is healing, and in healing there is stricture formation. Can you see? So can you see what kind of stricture? This stricture is passable or non-passable. So in majority of cases it is passable. So you can see there is formation of passable strictures. Clear? And if there is stricture but it is passable, patient is going to complain that, sir, after meals I'm having colicky pain. Why? Because there is obstruction. What kind of? Partial obstruction. But I pass feces and flatus. So patient complains of colicky pain after meals, but patient passes feces and flatus. This is not the complete obstruction. This is partial obstruction, and there is a term which we use commonly for such patients, and this is subacute intestinal obstruction. Why? Because when these patients are coming to emergency OT, yes, you insert the Ryle's tube, you keep patient NPO, you give fluids, and what happens? After Ryle's tube insertion and monitoring the patient for some time, what happens? Obstruction is relieved. So there are recurrent attacks of subacute intestinal obstruction, and because of this subacute intestinal obstruction, what is the most common symptom? And the most common symptom is abdominal pain. Clear? So in GI tuberculosis, what's the most common symptom? And that is abdominal pain. It is because of subacute intestinal obstruction. Now see the complications. Certain patients have acute obstruction, so it can present as acute obstruction, and if there is delay in the presentation, a patient is coming late, what happens? Because of obstruction there might be perforation. So see, what are the complications of GI tuberculosis? Complications of GI tuberculosis. Clear? So first, acute obstruction. What's the cause of acute obstruction? Generally it is because of some stricture, or sometimes there is fibrous band, or there is formation of matted bowel loops. If there is delay in the presentation, what happens? There can be perforation. Clear? And you know, in tuberculosis there is increased risk of fistula formation and abscess. fistula formation and abscess. Now coming to the investigations. Doesn't matter what kind of tuberculosis patient is suffering from. What is the most common laboratory abnormality? Suppose in our resident we are suspecting that resident might be having tuberculosis, so we send his blood for ESR. So the most common laboratory abnormality in tuberculosis, any kind of tuberculosis, and that is raised ESR. It is raised in more than 90% of patients. So see the list of investigations. First, the most common laboratory abnormality in tuberculosis, and it's the raised ESR. In how many patients this abnormality is detected? It is seen in more than 90% patients. Now second problem, in GI tuberculosis, since there is formation of matted bowel loops, see how these loops look like. So you can see these are the bowel loops, clear? And these bowel loops are matted. So what happens? There is formation of adhesions, these are matted, and in between bowel loops what happens? There is fluid collection. So what happens? There is fluid collection in between the bowel loops, clear? In these patients, if we are going to perform the ultrasound, if there is presence of matted bowel loops, this appearance is known as what? Club sandwich appearance. Why? Because there is alternate layer of bowel and fluid. So this is known as what? Club sandwich appearance. So if we go for ultrasound, on ultrasound we are going to find club sandwich appearance. Clear? So why? There is alternate layers of bowel and fluid in between these loops. You must be knowing that in tuberculosis there is ascites also. If the patient is having gastrointestinal tuberculosis, patient might develop ascites. And if there is ascites, means collection of fluid. What kind of fluid is collected? It is exudate or transudate. So since it's a local inflammatory situation, it's exudate, and if it's exudate, relatively the protein content is high. One important statement. Second, tuberculosis is a chronic inflammatory condition. So in this case, there is recruitment of which cells? Lymphocytes. So whenever we are going to aspirate the ascitic fluid, so that is known as paracentesis, and we are sending this fluid for examination, we are going to find what? Lymphocytosis. The protein content will be more than 2.5 gram per deciliter. So see, if we perform paracentesis, okay, so on paracentesis, first there will be lymphocytosis, clear? So you have to remember the number of lymphocytes, more than 500 per mm cube. Okay, second, the protein content is relatively high. So how much should be the protein content in ascitic fluid? More than 2.5 grams per deciliter. And if we are going to calculate SAG, what is the full form of SAG? It's serum ascitic albumin gradient. It means serum albumin minus ascitic albumin. So whenever ascitic albumin is high, what will happen? The SAG will be low. So generally it's less than 1.1. So whenever there is exudate, it is less than 1.1, and whenever there is transudate, it is more than 1.1. And what is the laboratory investigation by which you can confirm the diagnosis? ADA. So there is raised adenosine deaminase. All these are asked in exam. So there is raised ADA. So these are the findings of paracentesis. By the way, what is the investigation of choice for diagnosis of GI tuberculosis? Yes, it is CCT. So you have to remember that investigation of choice for diagnosis of GI tuberculosis, and that's CCT. Very important point. If you have seen PGI Chandigarh paper, almost every year in that exam there was one question related to barium meal follow through findings of GI tuberculosis. So it's very important, asked in both surgery as well as in radiology. See, what are the findings of barium meal follow through? Barium meal follow through findings in gastrointestinal tuberculosis. It's very easy to understand. Now first see, this is the cecum and this is the ileum. Clear? This is appendix. So see, how much is this ileocecal angle? Generally it's close to 90. Ileocecal angle is close to 90. What happens in GI tuberculosis? There is contraction of mesocolon. Clear? So whenever there is contraction of mesocolon, because of this contraction of mesocolon, the cecum is pulled up. So what will happen? Cecum is pulled up. So the location of cecum is in right iliac fossa. Generally cecum goes to right lumbar region. So if cecum will be pulled up, can you see the cecum will reach here? So what will happen to IC angle? Yes, the IC angle will become acute or obtuse. So it is more than 90 degree. So it become obtuse. So what's the change? There is obtuse IC angle. And why there is obtuse IC angle? Because of contraction of mesocolon, there is pulled up cecum. So it leads to pulled up cecum and there is obtuse IC angle. This deformity is known as goose neck deformity. So what's the name? It's known as goose neck deformity. All these are important, asked frequently in exam. Okay, one important point. Now see second important point. This is the ileum, cecum, this is the appendix. We discussed that there is formation of this kind of transverse ulcers where in the ileum. Because of that, ileum becomes hyper irritable. So there is rapid emptying of content from ileum into the cecum or colon. Whenever we are using barium, there is rapid evacuation or emptying of barium also into the cecum. So ileum appears narrowed and this is known as Sterling sign. So what's the problem here? There is narrowed appearance of ileum. Narrowed appearance of ileum, and this is known as Sterling sign. What's the cause? Here it's because of hyper irritability. So it's Sterling sign. Clear? Now see, whenever there is formation of established stricture, so if there is established stricture, what's the problem? There is persistent narrowing of ileum. Persistent narrowing of ileum because of established stricture, and this is known as string sign of Cantor. You see, imagine this is the cecum, this is the ileum. Now what is the problem? This is the established stricture and this is the normal ileum. So this established stricture, what happens? There is established stricture, and because of this established stricture, there is persistent narrowing of ileum, and this persistent narrowing, this is known as string sign of Cantor. String sign of Cantor. Clear? So narrowed appearance of ileum because of ulceration leading to hyperirritability, Sterling sign. Persistent narrowing because of established stricture is known as string sign of Cantor. Now see another sign. In patients of GI tuberculosis, sometimes there is rigid cecum. Rigid cecum, thickened IC valve and narrowed ileum. So it looks like umbrella. So what's the name of this sign? Umbrella sign. It is also known as Fleischner's sign. So another sign. This is umbrella sign. It's also known as Fleischner's sign. Umbrella sign or Fleischner's sign. What are the findings? There is rigid cecum, thickened IC valve and narrowed ileum. Clear? So these are the important findings on barium meal follow through. Now see, any patient in whom there is presence of ulcer in the ileum and ileum becomes hyper irritable, what happens? There is narrowed appearance of ileum. So Sterling sign can be seen. And you know that in Crohn's disease there is presence of ulcers in the terminal ileum. So Sterling sign can be seen. Second, any situation in which there is established stricture in the terminal ileum, in those cases you can find what? String sign of Cantor. So the same story happens with Crohn's disease again, that in Crohn's disease there is established stricture in ileum. So Sterling sign and string sign of Cantor, these are non-specific. It is not only seen in tuberculosis, it is also seen in Crohn's disease. Okay, so see these two, Sterling sign and string sign of Cantor, these two are seen in both. These two are seen in both first GI tuberculosis and second Crohn's disease. This was asked many times. Clear? So these are important points related to barium meal follow through. Now see, diagnosis is done. So how we are going to manage these patients of tuberculosis? So we have to give ATT. Simultaneously we have to manage the complications. So what's the treatment? It's the ATT, anti-tubercular treatment with management of complications. Okay, so generally it's the medical management. But what happens, some patients come to us to surgery department with complications, and in those cases surgery is required. So in which cases surgery is required? So what are the indications of surgery? You have seen such patients in surgery OT or in surgery emergency. First, acute obstruction. Clear? If there is delay and patient is having perforation, so what? There is perforation peritonitis. Clear? If there is bleeding, there is abscess or fistula formation. Bleeding, abscess or fistula formation. Clear? So in all these cases generally we do the surgery. So surgery is done in all these patients.